Hello, friends. It's an opportunity for us to look at some of the very challenging aspects through which coronary surgery has emerged over the last 2 to 3 decades. Whenever we have a chance to look at the current evidence, the evolving ideas and the challenges of PCI vis-a-vis coronary surgery, we have in the past taken a very adversarial position. I really think the perception is not of a conquest. The perception is not one of a battle, but it is a scientific environment in which we look at the evidence that supports either methodologies for correcting a problem which has been a threat to our lives and living for time immemorial. We have been a victim of oversimplifications. We have been a victim of academic nihilism, and we have been a victim of industrial over-enthusiasm. But through all this, science must prevail. So let this be an opportunity where we look at some of the evidence that presents on either side and that gives us a fundamental basis on which our surgical and clinical practice can be based on. Let's begin. Hello, it's a real pleasure to be having the opportunity to make a presentation to my friends and colleagues on a subject that has continued to be a topic of discussion probably for the best part of the last 2 decades. And with a little bit of humor in the beginning, we have labeled it as a face-off from the classical Western when you had the cowboys chasing the Indians, or perhaps more often than not chasing one another. The cardiac surgeon has been proverbially used to the habit of being a big fish in a small pond, till somewhere about 20 odd years earlier something happened like this, that a big bird ran away with the big fish. And our lives' stories can be traced back to 1977 when this young Swedish cardiologist Andreas Grundtvig thought he had a very clever idea of solving blockages with balloons. But the whole of the scientific community was really outraged, and Andreas Grundtvig was not even granted with the paper acceptance, and he desperately had some space in the wall where he put up a poster showing the process of angioplasty, which has been one of the most earth-shattering discoveries of clinical medicine in the last 3 decades. 2003 was really a sort of game changer when the world's first drug-eluting stent came in, and that started a series of discussion as to which of the 2 methodologies were more successful. And as a clinician, either as a cardiologist or as a surgeon, we were literally inundated or buried under the evidence of clinical trials, one after the other after the other. This is a very busy looking slide, but basically since the inception of angioplasty, this enumerates the trials which has taken place starting from our Barry to Iraqi to right up to the recent Syntax and pre-combat. And perhaps there was a time when people thought that we had more trials than patients. As a surgeon, we have reason to be justifiably aggrieved because some of this flurry of statistical data that was outpouring from all over the world passed us by for some time, because we can really feel aggrieved to think that we have been tricked. And what was the trick? The trick really was that the investigators set out to investigate symptoms like repeat revascularization, MACE events. And at the end of it, when there was significant difference in these parameters, they claimed equivalence in methods through mortality figures. The fact of my life was that these trials were not powered to look at mortality at all. At last, through years and decades of when surgeons and cardiologists were agreeing to disagree, I think civilization dawned on our specialty with the construct of the Syntax trial in 2009. And perhaps for many more years to come, there will not be a scientific investigation like the Syntax trial. Now, briefly, why was Syntax trial so precious? Why was it so unique? Simply because it was an all-comers trial, an all-comers registry. First time through this trial, we learned how to score coronary artery disease instead of repeating subjective and descriptive terms like the end of a thread. So the Syntax score evolved as a part of this trial. This is the first trial where cardiologists agreed to meticulously follow up patients for 5 years, and they also agreed to adhere to the statistical endpoints. The goalposts will not be changed in course of this investigation, and this was termed a non-inferiority trial. Syntax is now a part of history. So I do not want to bore all of you slide by slide from year 1 to year 5. But if we look at this rather busy looking synopsis of 5 years, then it is very fair to conclude that at the end of 5 years, coronary bypass had significant advantage in terms of myocardial infarction, all-cause death, and the survival up to 5 years, and cardiac death is to 5 years. So all these very significant hard endpoints were superior for coronary bypass. But having kind of won the battle on these 3 or 4 fronts, we did have our points of weakness, and coronary surgery was a bit weak as far as cerebrovascular stroke incidence was concerned. And at the end of the first year, there was a distinct difference in the incidence of stroke at 2.2% for surgery, 0.6% for angioplasty. And though the surgeons argued that some of this difference was evened out at the end of 5 years, but we have to accept that stroke remains a major point of worry as far as we surgeons was concerned. But there are certain aspects which we need to scrutinize a little bit more closely. And let us look at the MACE events for the low score Syntax group in the score of 0 to 22. Many of the parameters were comparable, but revascularization, even at the very comparable low score groups, was almost significantly higher for angioplasty at 23% as opposed to 16.9%. It was short of statistical significance by a whisker. If we look at the intermediate group, then by the time the Syntax score increases to 23 to 32, now the differences both for revascularization and infarct becomes resoundingly significant. And when we have the high-risk Syntax group at more than 33, then obviously the differences are earth-shattering. So what we are trying to say over here again, that when the 5-year conclusions of Syntax came out, the cardiologists could not resist the temptation of a little trickery again. The equivalence of PCI in low Syntax score triple vessel disease is a figment of the imagination, and we will serve our patients better to accept that even in the low-risk group, in triple vessel disease, surgical performance was superior. Syntax gave way to another very mature trial, and that was the FREEDOM trial, which looked at multivessel stenting versus coronary bypass in diabetics. And the conclusion from the FREEDOM trial was very significant. And before we come to the conclusion, let's remember that the distribution of patients in the diabetic group was very similar to what we see in real life. There was a large population of patients in the intermediate group, in the low-risk group, and a smaller distribution in the high-risk category. So in this trial, patients with diabetes and multivessel disease were kind of compared for bypass and drug-eluting stents. And the results again for multivessel disease for death, MI and stroke was superior for bypass. For myocardial infarction at 5 years was distinctly similar for coronary bypass. And what was again enormously different was the rate of repeat revascularization at the end of 5 years. So, led by Professor Foster's group, the FREEDOM trial concluded that in patients with diabetes, CABG was of significant benefit. Coronary bypass was distinctly superior to percutaneous interventions, irrespective of the syntax score. This is something we have to emphasize over and over again, that superiority in diabetes is irrespective of the syntax score. And the second most important thing is about the difference between bypass and angioplasty is the difference between an affair and a marriage, because like a marriage, the superiority of bypass seems to improve with time. Because when we go beyond year 3, year 4 and year 5, really the resounding clinical difference between angioplasty and coronary bypass opens up. A trial that has been very elegant in its statistics but not often discussed very popularly is the ASSERT trial, because the ASSERT looked at the STS and ACCF database and looked at a large number of patients, more than 20,000 patients, which was basically in the trend of a meta-analysis. And we can talk about the ASSERT trial for hours, but we can make a synopsis to say that even look at ASSERT trial at about 4 to 5 years, the difference between coronary bypass and angioplasty survival is opening up. What about the real life? Unfortunately, we again fall back to the New York registry. There isn't much registry data from Asia, from Europe. So we look at the New York registry data from Hanan. And Hanan has shown us that the 2-vessel disease and 3-vessel disease, especially where the proximal LAD is involved, results tend to be markedly different at 3 years. And when he looks at the overall survival of more than 60,000 patients over 3 years, the difference between these two methods are there for all of us to look at and admire. A word needs to be said about left main. Much water has flown under the bridge about left main. There has been thousands and thousands of papers, series, a few trials. But at the end of the day, the charge for the left main was led by Professor Park from Seoul, South Korea. And Professor Park had a brilliant trial in terms of pre-combat, but it was statistically very soft. And in spite of being a very biased construct, what it did show us was that target lesion revascularization was twice as high for the left mains, even in Professor Park's own trial. And left mains do not exist as a singular esoteric entity in the world. 37% of left mains have 3-vessel disease, 30% have double-vessel disease, only 13% of left mains are isolated, and hence we cannot use left main as a stick to beat the surgeon with, pretending that it is an isolated morphological entity. It is not. A specific area in which I think we have a lot of answering to do is in the domain of primary PCI, because that is where today's Frankenstein is being created. Less than 20% of primary PCI patients, in the name of curing or saving a patient from a ST elevating infarct, are completely revascularized. And especially in our situation, less than 20% ever undergo a supplementary procedure. And just look at this study from Marco Grossi some years back, which distinctly shows that incomplete revascularization is a curse as far as treatment of coronary artery disease is concerned. And if you just have a mental impression of what the curve for incomplete revascularization looks like, is very much similar to the survival figures from primary angioplasty, because primary angioplasty in a vast majority of cases essentially results in incomplete revascularization. But this is where we surgeons are not faring well at all, which is, even if we refer back to the 2014 guidelines for myocardial revascularization, just look at the lowermost column, where it says that in patients where PCI is not possible, for STEMIs, CABG is an option. But look at the very last column. The reference column is put at a blank. So why is the reference column blank? Because we surgeons have been so lazy in operating in the acute setting that there are very few papers and trials to go by. I have made my search and have come up with some data, one from the Journal of Thoracic and Cardiovascular Surgery, which basically shows that from 3 days hence, in a case of a STEMI, the surgical group risks for operating on this group is pretty optimum. And if we do look at a comprehensive figure for surgery in the acute setting, we have to quote Rastan from Circulation. And Rastan basically looks at cases where he has operated with cardioplegia or on the beating heart, and the mortality is around 8% and 5.7%, which is pretty respectful considering this very difficult cohort of patients. Edward Hanan, apart from looking at registry, also looked through the number of patients who were having angioplasty which were thought to be inappropriate, because this is not a topical issue only in India or elsewhere in Asia. Inappropriate angioplasty is a very topical issue out in the United States. And if you look at Edward Hanan's data, then 14% of all records which were reasonably comprehensively kept was found to be inappropriate indication for angioplasty, and he kind of surmises that if you include all comers in it, then probably the incidence will be more than 20%, and this is United States, this is not India. Friends, if we bury the hatchet and want to look back at one evidence-based source, which is a comprehensive kind of Bhagavad Gita for revascularization policies in coronary disease today, it has to be the 2014 ESC and EACTS guidelines on myocardial revascularization. And my plea to all of you is that the sooner we left our egos back at home and read out this almost 50-page document in word and spirit, the more we know where we stand, the better will be our practice. But certain political events have happened as far as even the guidelines is concerned. From the 2010 guidelines, if we look at the 2014 guidelines, which has come out only in August this year, there has been certain difference in recommendation in one vessel disease and left main disease. They have been upgraded from 2A year before to 1A in 2014. But unfortunately, the references that support this upgradation of recommendation is pretty weak, it's pretty feeble. And I had an opportunity in the last International Coronary Congress in New York to interrogate some of the people who were in the committee, and they just, smiled the smile of a politician and said that certain political adjustments had to be made. So look, politics is there everywhere for us. But one of the sort of philosophies that came out of the international guidelines was the formation of a heart team, which should include the surgeon, the interventional cardiologist, the non-interventional people, and probably you can extend it even further, the patient's family, their relatives, But unfortunately, decision making in India looks something like this, because whichever clinician manages to grab the patient, it is I, me, and myself. And that is where the patient has every right to feel cheated at the end of an incomplete clinical counseling. A little bit about the world today. Now, if we look at the coronary artery disease as a composite entity, this once again is American statistics, then out of 15 million Americans who were kind of looked at in the database, remember that 90% of people are still treated on medicines, on medical treatment. Only 8% have angioplasty and 2% of coronary bypass. So as far as the reach of therapy is concerned, intervention is still far behind, and it should justifiably be far behind medical management. As far as cardiac surgery per million population is concerned, we in India is still just having our noses above water in doing 100 surgeries per million population. US stands at 1,000, Japan stands at somewhere like 500 per million. So we've got a long way to catch up. But what it really means is, if you look at the fact that India does about 100,000 cardiac major operations in a year, then if we did increase to the levels of somewhere near the Japanese or the Taiwanese figures, then just in so doing, the number of cardiac operations in India is bound to go up by a factor of 3 within the next 3 years. And whatever little data we have from our own country, it suggests that the annual compounded growth rate for cardiac surgery in India is about 12 to 15% right now. What is the international standing? How many angioplasties are done vis-a-vis bypasses? For us, we think in India the ratio is 2.5:1. It might as well be 3:1. And this compares, really, China does very few bypasses a year. China only does 30,000 bypasses for a staggering population of 3 times the size of India. And Japan only does about 16,000 per year. So in India, we are performing 90,000 odd coronary bypasses and not really doing too badly at all. But where this bout will be won and lost, friends, is in the domain of triple vessel coronary artery disease. And if you look at it today, then in triple vessel coronary artery disease, 75% is surgical substrate, about 25% is for angioplasty. And in India, it basically means about 40% and 40,000 and 72,000 cases respectively. But this is what you and I will have to hang on to. And what does the future hold? This again is American data, because what is really happening in the civilized world as far as coronary heart disease is concerned, that the elective patients, the cold patients, are really less, because the incidence of disease in civilized communities or developed communities is decreasing. So what is increasing is the detection of unstable patients, acute STEMIs. So coronary bypass probably still stands to increase over the next decade. There will be a downturn of angioplasty. The numbers are coming down, and medical treatment will definitely increase with the refinement in not only in the molecules, but surgeons and physicians will get to know which are the cases not to operate on or not to do an angioplasty on. And this is really the New York State annual figures, which is right up to 2013, which shows that from 2011 onwards, the number of angioplasties are on the decline. And there is a specific reason for it, because nothing moves in America without money. And what's really happening is that the guidelines as to what constitutes a proper angioplasty has now reached the insurance paymasters, and they are comparing every case record which is submitted to them against the guideline parameters, and if they are unhappy, they will withhold payments. If payment is withheld, the hospital goes bankrupt, and a bankrupt hospital at the end of the day means a bankrupt cardiologist as well. So, friends, if we surgeons have a job in hand, our job is not to feel very happy and very smug that, look, world over, coronary surgery is showing a resurgence. The work is cut out for us where we have to follow up primary angioplasties and get into the domain of operating more in acute cases justifiably. We have to establish our presence in the outpatient departments and heart teams, and we have to sensitize the paymasters in India as what constitutes a proper guideline of both CABG and angioplasty. So the message perhaps is, friends, hold your ground. And I end with a reference to Professor Park from Korea, again, one of the most aggressive proponents of adventurous angioplasty, when he made a comment in Nature. This is not, again, as you know, a very respected science journal. It's not just a journal of cardiology. So Nature in May 2018, Professor Park comments, based on the current strength of evidence, that CABG is still the preferred option for treatment of multi-vessel disease. So coming from Professor Park, it is probably can be considered to be the gospel as of today. No lecture can be complete without introspecting as to what is our own weaknesses. Our weaknesses still remain that a large number of bypasses are basically unverified procedure. We do not do early angiograms. 95% do not have a flow study. Surgeons are still shy of acute coronary syndromes. Cardiologists may argue that we are primitive because less than 5% of all coronary bypass use a second arterial graft, and a real challenge is to decrease the stroke rate to less than 1%. So, friends, in spite of all the quarrels we have, in spite of all the data that may conflict one another, the story at the end of the day is a story of coexistence. And just before dinner time, I'm tempted to show you this 1-minute video, which is what is called clever collaboration. So if 3 people standing side by side, they can collaborate on this, then both medicine, intervention and coronary bypass can clinically collaborate in the years to come. Thank you for the opportunity. Thanks.
Excusez-moi, vous pourriez la tenir 1 minute?
Bien sûr. Désolé, j'ai fini. Oh, c'est bon, allez-y, je me charge.
J'ai terminé.
Moi aussi.